Hello, everyone. It's indeed a great honor to be able to come to you on the occasion of this UIP International Congress in Buenos Aires. Today, we're going to discuss a very, very controversial topic regarding VTE treatment, measuring the risk of recurrence. Here are my disclosures. And let's begin with a study of a 62-year-old male who underwent outpatient right knee arthroscopy lasting 70 minutes and was not weight-bearing postoperatively and using crutches due to pain for the first 5 postoperative days. The Caprini score was 7, age, surgery, non-weight bearing, and a BMI of greater than 30. However, no thrombosis prophylaxis was prescribed. The patient developed leg swelling and pain 10 days later in the operated leg, and an acute popliteal DVT was discovered. Treatment for 3 months with therapeutic anticoagulation and a 20 to 30 millimeter stocking resulted in resolution of the clinical symptoms. On the left, you see the view of the popliteal clot, and here we are in cross section. Again, the clot is noted there. The patient was treated with anticoagulation, which was stopped after 3 months. He was encouraged to continue to wear the therapeutic stockings. 5 months later, the patient presents with a swollen right leg, noticed while sitting at his computer for several hours. The duplex scan documented a large proximal DVT with evidence of distal chronic changes in the right leg. Treatment with therapeutic anticoagulation and compression stockings was prescribed. The patient was treated for 1 year and transitioned to prophylaxis with a direct oral anticoagulant on a permanent basis. This is the picture of the recurrent clot involving a major part of the femoral vein. Now, this was a provoked clot, and the treatment suggestions for provoked clot include 3 months of anticoagulation, as we prescribed. And if the clot were to be unknown cause, then extended prophylaxis would be suggested. These are the current guidelines. And I would suggest to you that these recommendations are now becoming of historical importance only. We have to consider other things. Sam Goldhaber, who's a pioneer in venous thromboembolism and pulmonary embolism, he and his team at the Brigham and Women's a number of years ago postulated that provoked and unprovoked clots may occur in the presence of patients with other risk factors. And because of those other risk factors, that may turn a simple situation of a provoked clot after surgery or immobilization to a very complex situation requiring ongoing prophylaxis. The team suggested that VTE is a systemic vascular disease because the thrombus usually contains abundant polymorphonuclear leukocytes, neutrophil extracellular traps, and activated platelets. And we'll get back to that in a little bit. It's a very important postulate. Optimal VTE management frequently requires a more nuanced approach than simply provoked versus unprovoked. And examples of that are based on the pathological observation, which ties together long-standing epidemiologic links between inflammatory disorders, such as psoriasis, rheumatoid arthritis, Crohn's disease, and also inflammatory bowel disease, and venous thromboembolism. These are linked. When these inflammatory illnesses remain clinically or subclinically active, the risk of VTE recurrence remains high, although associated VTE is characterized as provoked rather than unprovoked. So that in these types of patients, you have to approach them a little bit differently. And one of the ways is doing a risk assessment using a validated score, which is critical to the overall evaluation. I suggest the Caprini score because it's 40 risk factors and I've worked on it my whole life. However, there are other good risk assessment scores. And there, as you know, there's many roads to Rome. So there's many ways to assess patients. So it's important concept to assess them by some means that has been validated. Now, very recently, again, back comes the Brigham approach and the Harvard Medical School. They've now taken their previous discussions and a major trial has appeared called the High Pro trial. And this involved provoked VTE, which are typically considered lower recurrence rate after 3 to 6 months of anticoagulation. But there's a gray area in patients with persistent risk factor. We've just discussed a lot of those gray areas. And the High Pro trial tested apixaban 2.5 milligrams BID for 12 months versus a placebo in such patients. And these patients were provoked VTE with at least one additional risk factor. And the intervention was apixaban, control was placebo. Primary outcomes were symptomatic recurrent VTE, efficacy, along with major bleeding, which for a safety issue. And the results of the trial, as it was going on, showed that recurrent VTE in the apixaban group was 1.3% versus the controls was 10% with an excellent hazard with a hazard ratio of 0.04 to 0.36, absolute risk reduction 8.7%, and the number needed to treat was 12 to prevent one recurrence. So the trial was stopped. Major bleeding was 0.3% versus in the placebo group was zero, and clinically relevant non-major bleeding was 4.8%, and the number needed to harm was 33. And it was concluded that the best candidates for provoked VTE were in the presence of risk factors such as obesity, inflammatory bowel disease, chronic lung disease, with low to moderate bleeding risk, and the trial provoking factors, immobility, 33%, or surgery 33%, immobility 31%, trauma 19%, and acute illness 18%. So the strength of this trial was a large relative risk reduction with a low bleeding rate. Limitations, single center, modest event counts, no comparison with aspirin or other DOAC strategies. 12-month duration only. So the bottom line, apixaban 2.5 milligrams for 12 months reduces recurrent VTE with a 9% absolute in high-risk provoked VTE patients. Very low major bleeding risk with a slight rise in non-major bleeding. Number needed to treat, 12. Number needed to harm, 33. So that all of a sudden now we have a shifting paradigm, and this is really a game changer and introduces a whole new concept based on older ideas, of course, that were now proven that thrombosis can recur in provoked patients even after standard therapy. And the current guidelines may not protect all patients as some remain vulnerable. And a personalized anticoagulant approach may help prevent recurrences and improve outcomes for patients at risk. Now, here we come to a very important point for anyone treating patients. It's fine to follow the guidelines, but when newer data appear that are solid, such as this New England Journal of Medicine article, you have to incorporate that in your patient practice so that you don't treat guidelines, you treat patients. So you have to consider new data that's appeared since the last guidelines. Very important postulate. Now we know that inflammation and thrombosis are mutually reinforcing processes. Inflammatory mediators activate anticoagulation, and coagulation factors amplify inflammation. This crosstalk is central to the pathogenesis of many acute and chronic diseases. When clotting occurs, inflammatory cytokines, sirens known as cytokines, are released, which attract inflammatory cells to the area of the clot. The first responders are neutrophils, and they'll be replaced by so-called monos, lymphocytes, histiocytes, and they come in and ultimately plasma cells in a few days. By 3 days, the inflammatory cells will develop into fibroblasts that will enter the vein lumen surrounding and invading the thrombus. And naturally, this process is designed to prevent the thrombus from embolizing. And by 5 days, the macrophages will break down red blood cells, releasing iron and hemoglobin. The iron will concentrate and become hemosiderin deposited in the thrombus. By 8 days, endothelial cells appear, forming new blood vessels into the core of the thrombus. Fibroblasts will proliferate to start forming a scar. Fibrinolysis occurs, breaking down elements in the thrombi, and the residual scar will depend on the effectiveness of the lytic process and the presence of antiplasmin activity, such as plasminogen activator inhibitors. Histologic examination of the clots during autopsy can be critical for determining the timing and extent of the thrombi related to clinical events prior to death. This is an incredibly important concept that's often overlooked in cases where patients die of fatal pulmonary emboli. It's very important to take a look at the clots in both the legs and the lungs, both grossly and histologically. And one can get a pattern of clotting because the most common pattern isn't suddenly after surgery, somebody wakes up someday and a big clot goes to the lungs and kills them. The pattern is that clots develop slowly in the legs, and when they're not treated with anticoagulation or inadequately treated, the clots grow. And and some of them will break off, but some of them that have been there for a few days will remain. And so the remnants of these clots will be seen and can be analyzed histologically as described above. And so it's a very important forensic pathway that can sort out many of these issues regarding deaths from pulmonary emboli. Now, what do we learn from COVID-19? Well, we know that COVID-19 was a virus-induced inflammation triggering a cytokine storm, causing tissue factor release, thrombin generation, and fibrin formation to coat the virus and prevent spread. What a beautiful concept. The unfortunate side effect was not only thrombosis, but activation of multiple systems, as we'll talk about that. For the first time, we're seeing in numbers primary pulmonary thrombosis because the virus attacks endothelial lining, and wherever there's a blood vessel, there can be a potential clot. And here we see the very beautiful alveolar endothelial interface in the lungs, which were a primary target for the virus. And you can see all of the reactions that are occurring here doesn't cause or result only in thrombosis, but also in the inflammatory pathways and the immunologic pathways. And also the virus uses the ACE2 receptor, binding it to the spike glycoprotein on the viral envelope to help to enter the endothelial cells. Now, I'd like to talk a minute about Oscar Ratnoff, who was a famous hematologist. And Oscar and his colleague Davies came up with the clotting cascade. And as a matter of fact, Oscar often mused that he was a little disappointed he didn't win the Nobel Prize for that. Nevertheless, he studied contact activation because he had a patient, John Hageman, and he discovered in him factor 12 deficiency. And Oscar went back and looked at the literature, and he found 4 experiments done before the turn of the 20th century that conclusively proved that when the contact activation sequence of the clotting cascade, starting with factor 12, was activated, it activated platelets, coagulation, fibrinolysis, but also the inflammatory and immunologic pathways. So you had an immunologic pathway activated in the absence of an antigen-antibody reaction. And the results were not only thrombosis, fibrinolysis, but increased vascular permeability, vasodilatation, bradycardia, angioedema, histamine release, and hypotension. And I want to read the following statement to you because it is emblematic of how the body works and how we all need to be thinking about the body processes. The thesis of my talk is not new, he said. We think about clotting, fibrinolysis, immune reactions, and inflammation as if they were separate and separable processes. In truth, these distinctions are man-made. In real life, it is the body as a whole that responds to the injury. The processes through which it defends itself are interlocked like pieces of a jigsaw puzzle. We may be intrigued by the intricate individual pieces of the puzzle, but the picture emerges only when they are put together to form the final product. Bravo, Oscar Ratnoff. Now, we also learned very early on that anticoagulation alone is not the answer. Subsequently, we figured out that if you gave enough anticoagulation early enough, you could prevent that spike or that influx of the activation of the clotting factors to further stimulate the virus in the body. So that did help to some extent. Now, there are newer approaches to address both coagulation and inflammation since we know that they're interrelated. And these are the P-selectin and E-selectin inhibitors. They target the interface between inflammation and thrombosis, a central mechanism in deep vein thrombosis. These selectin molecules are cell adhesion proteins that play a key role in the leukocyte endothelial interaction, platelet aggregation, and thrombosis propagation. The P-selectins activate platelets in endothelial cells, and that promotes platelet leukocyte aggregates, increases tissue factor expression, and accelerates thrombin formation. E-selectin activated endothelial cells mediates leukocyte rolling and adhesion, which contributes to inflammatory recruitment at venous valve sinuses. Selectins facilitate the recruitment of leukocytes to the site of endothelial activation, particularly in the areas of low shear stress, like deep veins, fostering a procoagulant environment. These are the key references regarding the P-selectin and E-selectin inhibitors. Now, what about markers linked to recurrent thrombosis? Let's talk about D-dimer, which is a fibrin degradation product that becomes elevated in the presence of active clot formation and breakdown. While its primary use is in ruling out acute VTE in low to intermediate risk patients, there's growing interest in its role as a predictive biomarker for recurrent DVT, particularly after an initial unprovoked event. The prolonged study by Pallarati in 2006 showed that patients with an elevated D-dimer after stopping anticoagulation had a recurrent rate of 15% per year versus 2.9% in those with a normal D-dimer. The reverse study by Roger in 2008 among patients with unprovoked DVT and PE, those with elevated D-dimer 1 month after stopping warfarin had a 9.3% recurrence risk over 1.4 years versus 3.5% with a normal D-dimer. Now, recently, the Apodulcis study, apixaban, for evaluating D-dimer and low dose apixaban to guide extended therapy, was a multi-center prospective cohort from August 18 to September 2021, enrolling 732 patients aged 18 to 74 who had received 12 months or more of anticoagulation after a first unprovoked or weakly provoked VTE. The D-dimer protocol was the baseline test was done during anticoagulation because if it's positive on anticoagulants, you're certainly not going to get a negative test off. So if negative, the patients had their anticoagulation stopped and were retested at 15, 30, and 60 days. If they were negative on all serial tests, anticoagulation was discontinued. Whereas with anyone who developed a positive D-dimer in any one of those time periods, which was 61% of the patients, were started on low dose apixaban, 2.5 BID for 18 months, sorry. An interim analysis led to an early study suspension comparing recurrence rates. The primary outcomes were recurrence or major bleeding. In the no anticoagulation group, there was a 7.3% incidence of VTE over 18 months, whereas in the low dose apixaban group, it was 1.1%, with a hazard ratio of 8.2, which favored continued treatment. So, the serial D-dimer testing following 12 months of anticoagulation is not reliable to safely stop therapy in the DOAC area. Extended prophylaxis with low dose apixaban is both effective and safe, dramatically reducing recurrent rates. As good as this trial is, and we're going to discuss this in a little bit, it was in absentia of the other markers of thrombosis. So while D-dimer alone is pretty well proven not to be reliable, we have to talk about some other things. Now, there are other ways to take a look at this problem of provoked versus unprovoked. And the HER2 concept is another important way to include D-dimer in the evaluation. And all men and high risk women with a score of 2 plus were treated with long-term anticoagulation, and low risk women with a score of 0 to 1 short term. There's also the DASH score, which can be used, and depending on the score, will give an annual recurrence rate, as you can see here. And with a score of 3, it's above 12.3%. Now, what about factor VIII levels? Elevated levels of factor VIII increase thrombogeneration, enhance fibrin formation, promote hypercoagulability. Unlike inherited thrombophilias, like factor V Leiden or prothrombin mutations, elevated factor VIII is often required and may persist long after the initial thrombotic event. The Leiden thrombosis study was one of the first studies linking factor VIII to a first VTE. Individuals in the highest quartile of factor VIII, above 150 international units, had a five-fold increased risk of a first VTE. Christensen, in a prospective study with patients with a first unprovoked VTE, found that, again, the 150 international units was associated with a doubling of the risk of recurrence compared to normal levels. And the Vienna prediction model incorporated factor VIII as a prognostic marker, and patients with a persistently elevated factor VIII after stopping anticoagulation had a higher recurrence, especially when combined with D-dimer or residual vein thrombosis. Aha, some new tactics. Now, one of the original articles about factor VIII was the mega study follow-up, where we know that factor VIII is a potent predictor for first venous thrombosis. And what was done in this study was a 6.9-year follow-up for recurrent VTE, which was 1.06 increase for every increase of 10 international units. The cumulative index rate seen for a strata of VTA for both provoked and unprovoked, which this was both provoked and unprovoked. Those with a level of over 200 international units had a threefold higher risk compared to those with a factor VIII level equal to or less than 100 international units. Here's the key evidence supporting factor VIII as a predictor of recurrent VTE. Now, elevated factor VIII levels were also tested in a mixed population with those on anticoagulation and a past venous thrombosis. 306 patients with a prior provoked or unprovoked VTE and had factor VIII levels were measured as a part of a thrombophilia workup. Those with a level of less than 150 units, 92 patients, whereas those with a level of over 150, 214 patients. Elevated levels were seen in patients with both provoked and unprovoked thrombosis. Very important. Venous ulceration was more common in those with abnormal factor VIII levels. Levels of 150 international units, here it comes again, was an independent predictor for recurrent VTE and more common in those with a family history of DVT or a personal history of an unprovoked DVT. And levels of over 200 international units was a significant predictor of occurrence of 2 or more episodes of VTE. The authors concluded that elevated factor VIII levels, particularly when the levels are over 200 international units, have important implications for secondary prophylactic strategies for DVT. We're hearing this same song over and over. And here is a COSME study showing the relationship between D-dimer and factor VIII as independent risk factors after a first idiopathic venous thrombosis. And these were unknown causes of clots. And if both tests were normal, there was a 6.4% recurrence rate in the 2-year positive. Those with abnormal D-dimer and a normal factor VIII, or a normal D-dimer and an abnormal factor VIII, the risk was 17 or 18%. But if both were abnormal, the risk was 34%, illustrating the value of testing both of these factors. Why is there such little attention to measuring factor VIII levels alone and in combination with other markers? Well, as important as all of these are, my colleague offered an explanation about why this is true, and we'll discuss that in a minute. Now, there's ristocetin cofactor, which is a functional assay used to evaluate to assess von Willebrand's factor activity by measuring its inability to agglutinate platelets in the presence of the antibiotic ristocetin. Elevated levels reflect increased von Willebrand's factor activity, often as a part of an acute phase or endothelial response. A, again, showed that a von Willebrand's factor of greater than 150% or factor 8, here it is again, over 150%, demonstrated significantly higher hazard of VTE recurrence. This prospective analysis reinforces the use of both markers. Here we are seeing both of these markers in addition to other evidence with the other markers of D-dimer and factor 8, so that a repeat story is being told by investigators over time, isn't it? And here are the key references relative to ristocetin cofactor and factor 8 levels as predictors of deep vein thrombosis. Now let's talk about residual venous obstruction. Residual venous obstruction, who was defined by one definition, was a persistent non-compressibility or residual thrombus of 2 to 4 millimeters in a proximal vein on ultrasound after 3 to 6 months of anticoagulation. The presence of it was associated with a 2.2 to 3 times higher incidence of recurrent DVT, whereas the absence of residual changes in this manner were suggestive of discontinuing anticoagulation. But they also suggested measuring biomarkers due to the length of anticoagulation. And residual venous obstruction in one study, this is Prandoni, which we're talking about. Cumulative recurrence rate 40%, provoked 22%, unprovoked 52%. These data forces us to question the notion that time-limited anticoagulation is an effective strategy because the rate of recurrence is high, even among those with provoked VTE. It is really important for us to understand the limitations of this because it's very difficult to standardize residual changes in the eye. It's in the eyes of the beholder. So this is a very nebulous area. And now, what do the guidelines show us? The guidelines show us that the treatment of provoked versus unprovoked clots differ primarily in the recommended duration of anticoagulation and decisions regarding long-term secondary prevention. Provoked DVT with a transient risk factor, such as surgery, trauma, immobility, or estrogen use, or persistent major factors, such as active cancer, and unprovoked was those without identifiable risk factors with only minor transient factors. Treatment: anticoagulation should be initiated promptly, regardless of whether the event is provoked or unprovoked. The first 3 months, full intensity anticoagulation with a DOAC is now preferred in most cases. So that's the guidelines. And this is chest, 3 months of anticoagulation, ASH, 3 months of anticoagulation, and European guidelines, 3 to 6 months. Now, unprovoked extended anticoagulation with no particular end date, according to the guidelines from all three organizations. And you have to assess patient risk, patient preference. Don't forget about patient preference. That's a very important consideration. And reduced DOACs are good for long-term prevention. Cancer-associated VTE, prefer low molecular weight heparin or DOAC, and the duration is pretty obvious as long as the cancer is active or treatment is ongoing. For unprovoked VTE, they also talked about predictors favoring extended therapy like high post-treatment D-dimer, residual vein obstruction, elevated factor VIII, or first VTE event, or a family history of VTE. So the guidelines are starting to take a look at some of the other literature and hint at this. And here are the key references and the guidelines that I quoted. These are the trials. So another thing that I did is I went to ChatGPT and said, tell me your suggested algorithm. And they suggested 3 to 6 months of post-DVT and compression ultrasound, and this for unprovoked DVT. checking D-dimer factor 8 and aristocetin cofactor. And if residual changes are absent and all markers are normal, suggest stopping the anticoagulation. If residual changes are present and one biomarker is positive, suggest continuing anticoagulation. If the residual changes are present and two biomarkers are positive, then long-term anticoagulation is suggested. That's ChatGPT, and here are the references that they used in order to calculate this. Now, what is my personalized approach for provoked and unprovoked DVT? Continue anticoagulation for 3 months, and if the residual changes are resolved, then proceed as above. And this is for all clots, provoked and unprovoked. And then we take a look at serial D-dimer and the other factors on and off anticoagulation in various time periods. And if the vitamin D, and I also like to keep the vitamin D levels at least 50 milligrams. Appropriate leg compression for at least the first year or as long as symptoms persist. Failures, start rivaroxaban 10 milligrams daily or apixaban 2.5 BID for the long term. Consider long-term anticoagulation for Caprini scores of 10 plus. Reevaluate annually and modify according to bleeding risk. Patient preference is always a key consideration in all of these, and it's very important. Now, while those things are all important and it's wonderful to do all of these, my colleague has pointed out to me that in terms of healthcare, on a systemic approach, on a national approach, uh, you can't always do all of these things in all of these patients, and all, especially in different countries, and especially with economic considerations and so forth. So the presence of the high pro trial is a good game changer for unprovoked clots. Now, don't forget to never kill a friend or never treat a stranger. Perform a thorough history and physical, gives you knowledge about your patient as if they were a good friend. So of course, once you know about them, you'd never kill them because you'd protect them. So you'd never treat a stranger and never kill a friend. Please have a look at my social media platforms. And don't forget about the wonderful VWin app, which is loaded with resources. And finally, stay tuned because I have invited my colleague, Dr. Alfonso Tafur, to join me in a discussion regarding plans of action, pitfalls, benefits, and continued approaches for further research. So I'd like to thank you all for your attention to this, and I hope everyone has a wonderful meeting. I'm very excited to be able to introduce my colleague, Alfonso Tafur, who's Director of Vascular Medicine at Endeavor Health and Clinical Professor of Medicine at the University of Pritzker School of Medicine, University of Chicago. And this is a very complicated subject, and I'm just delighted to have Alfonso come and give us his perspective about this subject. So, Alfonso, let me start off by asking you, how do you treat your patients? This is with provoked. Of course, this is with provoked.
The provoked unprovoked scenario.
Yeah.
So first of all, thank you for the invitation. And it's a little bit unfair, I'll say, to go and speak with the master after that very nice lecture you just presented. So start putting a few things into perspective, right? So what have I learned from you after so many years I practiced along with you, plus my own mistakes and ways of thinking. So one of the ways I think about it is provoked and unprovoked still helps me. Why is that? Because even though it's indeed oversimplistic, I will not toss it away completely. Surgical provoked event, epidemiologically, that already gives me a 1 in 100 people with those, assuming there's no other temporary risk factors, that will have a blood clot in the year after. So 1 in 100 people. Whereas the classical completely unprovoked event, especially if it is a male, I'm starting to count 7+% per year. And all of those numbers, when I understand epidemiology, have a confidence interval. There's this beautiful book called Super Prognosticators in which if you have a confidence interval, then you get the other variables to fine tune. And that's honestly what I do. So I have my initial range with provoked and provoked, making sure that that temporary risk factor is really gone. Because if it wasn't gone, if I have cancer as a risk factor, if I have persistent immobility, if I have morbid obesity, it just happens to be that the patient had surgery, but we haven't really fixed anything else. Then I aggregate genetics, family history, additional comorbidities, the biomarkers you talked about, to kind of build myself a pyramid in which I have provoked additional risk factors, scoring systems, and then I fine tune my estimate of risk, which I always reassess. I never say goodbye to the patient, thank you, you're going to be on anticoagulation forever, period. I tell them you're on it extended. And what does that mean?
Hmm.
It means I'm going to have to take a look at you again because the incremental benefit of anticoagulation is not eternal. Eventually, that same patient, and you've seen this 1,000 times, that same patient will have a bleed. It becomes cost prohibitive, so I have to go back to something less safe. The patient changes and starts falling, gets less support group, starts having bleeds. So I cannot predict that well. Therefore, I have to see the patient again and remeasure the incremental benefit of my assessment. So, in the short answer, provoke to provoke is my base, but I never stay there. And that's why it never made sense for me to just stay on that.
Very, very interesting. Now, of the various factors such as D-dimer, factor VIII, and ristocetin cofactor, how do you incorporate, if any of those, into your algorithm of how to how to approach the patient with a provoked clot?
Well, and you can use multiple scoring systems to help you. I mean, I don't have to just eyeball it and fine tune it. You have Predict VTE score, you have the HER2 score, which
Right.
integrate the D-dimer into the decision making. I would argue there's many other things that are not integrated, and I am hoping, if I was somebody with a crystal ball, that soon enough we'll be smart enough to integrate those other things that we haven't measured. There's technology, right? So I can just use a special ring or my phone, and it will tell me how much am I walking. None of the sports is telling me that right now. There's going to be integrated systems in your phone that tells you how is the weather, are you dehydrated, are you walking next to a community, do you have a good support group, which kind of measures the risk of other events happening on you. Then you're going to have the invisibles. So the technology has gotten to the level in which the Wi-Fi waves can actually rebound on you, and this sounds like sci-fi, but it's not.
Hmm.
Rebound on you and tell me what's your heart rate, tell me your height, tell me your fall risk, just because after all, waves are a Doppler effect. So smart machinery can now detect that even
Right.
without having any device on you. We are only touching the surface. We are so much used to this scoring system with the things that we have up to grabs. I'm hoping that in the next few years, we'll have much more sophisticated systems to be able to measure time and time again the incremental benefit of extended anticoagulation.
That was such a fascinating discussion and a set of remarks that I'm going to impose upon you to do a new video in the future where you describe these in detail because I see that, one of the things I still do is I'm a biker and I go on long bike rides, and when I do, I'm monitoring my heart rate all the time to make sure that nothing untoward happens before I get any clinical symptoms. And all these things that you can measure, and yet we're not measuring any of those or taking those into consideration. Now, I wanted to ask you about I've spent a lot of time with residual uh, changes, residual venous thrombosis, and where I have spent that time is by doing sequential studies and showing that patients that have residual vein thrombosis often had elevated pi-1 inhibitors when during the first stages of their anticoagulation, so the anticoagulation wasn't quite as effective and also had an increased incidence of post-thrombotic syndrome on the other end. And the other thing I would tell you is when I look at what the data is on residual vein thrombosis, I'm not impressed with that. But looking with my own eyes and based on my own research, I have this sort of unproven algorithm, if you will. Where do you stand on this?
Where do I stand on whether I introduce residual vein thrombosis into my algorithm? Let me give you an analogy. So if I measure my height, um, I'm supposedly 5'7". If I measure my height laying flat using the same ruler, I'm going to be a little bit longer.
Hmm.
So even with height, the precision of metrics can actually vary. Now, even worse, if I'm using a ruler in centimeters and then comes Joe and you try to measure me in inches or with your hands, you're going to have another different margin of error. Whether we like it or not, ultrasound as a technology is not good enough as to give me the same metrics all the time. That has been well proven. Linkins has multiple papers on that. For instance, if you have two different technicians measuring the length of a clot, blinded to each other, there's a margin of error of up to 9 centimeters, which sounds like a lot, but imagine a huge leg with a margin of error of about this length. I can
Yeah.
totally believe that. Amount of compression. Let's see that as a tall individual, 6 feet, pressing until the DVT, there's going to be an extra facility as to be able to compress it differently. And that changes the AP diameter, which also, even on the classic Brandoni studies, there was so much incremental change of
Hmm.
the prediction that he actually had to change his rule on the second paper. So if I'm measuring these residual thrombosis with techniques that are not reliable, then I cannot rely on that technique. And that comes to the data that you have, in which the only trial which is semi-convincing to me was the cancer DACUS trial, in which amongst patients with cancer, it seems to
Right.
have a benefit on prediction. In global patients with provoked event, seems to have a margin of prediction, but I don't think it's replicable enough as to have it very highly weighted in my decision-making process. Not because it doesn't work, but because it's measuring something I cannot replicate yet.
So what you have just demonstrated to me was a very classic example of when I described you, and I described this person coming into my practice that was younger, brighter, humbler, better educated, photographic memory, and all of that. Uh, I was sort of alone out in the wilderness, if you will, with all of the things that I was doing, and I was singing these songs, and you came in and you've given me a different song to sing. And now, after listening to you now, if I were still practicing, I would have a totally different opinion of how I approach residual vein thrombosis as I had when I am practicing. So I think this is a very important discussion, and it brings something that's very important, I think, to point out to the audience. And I happen to have just hit my 86th year. If you don't keep your ears open and you don't listen to what others are saying, you'll never learn anything. You'll be stuck. And so you really have to reach out and try to learn new things. And I think that's really fascinating. Uh,
If I may, that's the beauty of you guys being in Argentina right now and having difference of opinions among other experts just around you. Because otherwise we fall on this echo chamber and this confirmation bias is the technical issue. We fall on the confirmation bias, and I admire you, Joe, for being willing to listen, and I'm hoping that I'm willing to listen as well. So
yeah.
we recognize that we are not supposed to be always right.
Now, what we've tripped into with this discussion is the V-Win Foundation. Oscar Bottini, Sergio Genzini, Willie Chi, and you look at all of the lectures and stuff that they sponsor around the world. When a lecture is given, they have invited discussants from different countries giving their perspectives to try to cross-fertilize and try to digest what is going on and compare. You know, it's one thing for us to talk about things in one region, but in a different country, in a different locality, a different healthcare system, there are variations. And so those doctors have had to adjust to those variations. Imagine those people in the war-torn areas trying to practice medicine. And so there's differences. And by cross-fertilizing, which is very well done, and of course, classically also done by the UIP. We're going to have 80 countries at this meeting. And this cross-fertilization, I think, is really very, very important.
Your conversation reminds me of that paper we published some time ago, in which we can imagine practice as this Venn diagram. So data matters, of course, um, but it's not just about data. It's also about what your experience to see the world and what abilities that you have. Then you close that Venn diagram with the patient's desire. I mean, I had a patient today in which I wanted to
Right,
do extra things.
right.
And he looks at me, you know what? I'm 90. I have newly diagnosed pancreatic cancer. What's my perspective? And he was totally right. I mean, pushing as I was doing, it's not necessarily right with his desires. And then you have the environment that actually falls outside the Venn diagram, but you have the truth of policy and reality. I may want to tell you that I'm going to give anticoagulation forever to this individual, as in the high pro study, with low dose apixaban. Well, to some, that's over $600 per month, like here in the United
Right,
States.
right.
Now, with an NNT, so number needed to treat of about 12. So annualize that, that's 7,000 times 12. You're telling me that in social environment, community health, it's worthwhile to pay $70,000 to prevent one clot that is not necessarily a lethal one. Life is not measured in those kind of numbers, but I have to wonder if I was a policymaker, am I really going to make that decision?
I think that's a very, very important and brilliant observation, and I think that you've touched on something there that I think we have to come back to and never forget, and that is we have to always take into consideration the patient's preferences, and we can't give them such a stilted and one-sided argument so that they can't make any choice. We've got to give them a fair representation of the benefits and the risks of a particular plan of action. And also, I think what's really important that you said, I'd like to circle back on this just to sort of as concluding remarks, is this is an ongoing process. Uh, I myself have suffered from a pulmonary embolism. I'm on long-term anticoagulation, and my doctor, who I'm looking at, I periodically have to revisit that and revisit him. And although we don't have to test for the DOACs, we do have to test certain things and a general state of health and what is my risk of bleeding going up and so on and so forth. So those are really very important considerations. And then I want to say one final thing here which I think is really important, or one additional thing, and that is that once the high pro trial came out, and you're looking at the guidelines that say 3 months of anticoagulation for provoked, I think you have to be very careful not to treat the guidelines. You have to treat the patient. And when new data come out, that indicate a possible benefit and taking what has been all bet a black and white area and turning it into a little gray zone. I think you have to be willing to treat the individual patient according to the gray zone. And I think that's what you've done for your whole career.
You know, if I was to provide a very small nutshell for the audience, and maybe the nuance of trying to measure multiple biomarkers with different type of testing, with different parameters, and then combine them. That's a lot of nuance that, you know, you and I like because we breathe this, and even with that, we don't have certainty. But at the very least, it's not about provoked and provoked. It's about permanent or temporary risk factors. I think nomenclature failed us there. It was really about how long is the patient at risk.
Right. I think a classic example of that is patients with rheumatoid arthritis and chronic inflammatory diseases, where that really comes into play. So, Alfonso, it's been a great pleasure as always, and I hope the audience will enjoy our discussions, and I hope it will trigger some additional comments. And I thank you very much. It's been a great pleasure, and just like the politicians do.